So, good evening, everybody. We'll start the session now. The foundations to frontiers, the diagnostic evolution of multiple sclerosis based on biomarkers, that evolving biomarkers, which is a very important concept. We'll be briefly discussing all the biomarkers before we go on to the diagnostic criteria. So, the schema presentation will be introduction of MS pathophysiology, and the evolution of biomarkers, that is neuroimaging, and the evoked potentials, the CSF studies, and the recent advances what have come, and the Shoemaker, Poser, McDonald, Magnim's diagnostic criteria, and what are the misdiagnosis and what are the rates of improvement in diagnostic rates after applying the recent diagnostic criteria. We all know that the pathophysiology of MS, the hallmarks are inflammation, demyelination, and axonal loss. All can be captured on the neuroimaging with the various MRI sequences. The axonal loss will lead to the brain atrophy. So if you look at the etiology and the pathophysiology, there is inflammation, demyelination, axonal degeneration, and also mitochondrial injury, oxidative stress, remyelination, neuroplasticity. They all contribute to the clinical expression. You can see on this side, the biological, sex, infection, genetics, race, they all play a major part in the clinical expression of the disease. And one thing important is that inflammation and neurodegeneration are present at disease onset when it is diagnosed also. So you can see the exposure to risk factors, biological onset of disease, prodromal period, then clinical presentation and clinical course and evolution. So that's how the disease progresses. Frequent inflammatory events, that GAD enhancing lesions and relapses, lead to axonal loss, and it is clinically silent initially due to plasticity and remyelination. We are here at that stage. The shifting balance between ongoing inflammation and increasing axonal loss, the loss of remyelinating capacity of the brain, leads to brain atrophy, and subsequently, both the inflammation and degeneration takes its toll on the brain, and the chronic axonal loss, loss of remyelination, loss of brain volume, finally brain atrophy. So inflammation mediated by adaptive immunity, which I'm going to show in the next slide. Axonal loss, brain atrophy mediated by innate immunity that activated microglia. So immunopathogenesis of MS. The immune dysregulation in MS is characterized by the old concepts, now the recent studies, and they've got some meaning. The initial concept was the key role for CD4, CD8, and T cells. And recent studies have brought in B cells, natural killer cells, and myeloid cells. So now it is a multifaceted immune dysregulation. The innate immunity, and as you can see, the innate immunity will usually macrophages, mast cells, the natural killer cells, neutrophils, basophils, eosinophils, all these will lead to complement activation and generation of antibodies. These are the B cell mediated mostly, but the T cells have got another role, that is CD4 and CD8 T cells. So the slow response is adaptive immunity and rapid response is innate immunity. We have been studying this since our microbiology days, and various drugs have come out uh, based on this pathophysiology. So what are the current pathophysiology concepts? Inflammation and degeneration in MS is thought to be initiated by autoreactive T cells and other cell subtypes including B cells, NK cells, and myeloid cells, that is macrophages and microglia. During early phase of relapsing remitting MS, peripheral immune response targets CNS. In the late phase, there's a compartmentalized local inflammation within the CNS, and that leads to neurodegeneration. So these are the present concepts. Now let's look at the biomarkers, which are initially we'll be dealing with MRI and what are the various aspects of MRI that are important. Periventricular dissemination in space. The concept is that you have to identify these markers, these neuro images, when the lesions are in the periventricular region, then the cortical region, and the juxtacortical. You can see the juxtacortical locations are depicted here, and also the spinal cord lesions. So this is dissemination in space because various topographies are involved here, various places. And dissemination time, appearance of lesions at different times, and that will give rise to, you can have old and GAD enhancing lesions in the same, that also will tell us that it is a dissemination time. You can see the various MS lesions, the Dawson's fingers type, the spinal cord lesions, which should be, usually can see that it's only two segments, not beyond that, otherwise it becomes NMOSD. You can see the advanced MS cases show this. So the preclinical, relapsing, and secondary progressive. So the disease progresses like this, and with relapses and impairment, MRI burden of disease also increases, MRI activity increases, finally leads to atrophy. So these are the variants of MS with big lesions. So one concept is radiologically isolated syndrome. It can be defined as the presence of asymptomatic lesions typical of MS. So you do MRI for some other reason and you come across these lesions which are seen here, and what is the significance of radiological isolated syndrome, and if it is associated with a demonstrable IgG synthesis in the brain, then it becomes a diagnostic of MS. Now, something that has come up is a central vein sign, which you can see the vein in the center of the lesions here. And this is another biomarker, which is very much in speculation now. The central vein sign on MRI helps to differentiate multiple sclerosis lesions from other white matter changes like small vessel disease or aging. These lesions show a round or oval bright spots within a central dark vein, best seen on high resolution of a 3 Tesla or 7 Tesla MRI. The MS plaques form around small veins due to immune cell infiltration and blood-brain barrier breakdown, unlike ischemia or age-related lesions. The guideline is if over 40% of lesions have a central vein, it strongly indicates MS, helping differentiate it from conditions like small vessel ischemic disease, NMOSD, and migraine, which usually lack central veins. The clinical significance, it enhances MS diagnosis accuracy beyond the McDonald criteria and reduces misdiagnosis and unnecessary treatments. Towards the end, we'll discuss about the misdiagnosis. The other radiological finding, which is being discussed hotly, is paramagnetic rim lesions. The MS lesion and chronic active plaque and iron laden inflammatory rim. You can see the lesion core and inflammatory rim here and how they appear on susceptibility weighted image and T2 weighted image. You can see them. What are these PRLs? They are chronic MS plaques visible on SWI MRI scans, characterized by a bright center and a dark iron-rich rim. They persist for years, often appear in specific brain regions, and link to progressive MS and increased disability. PRLs serve as an important MRI indicators of disease severity and in treatment studies. These are the paramagnetic ring lesions, which you can see the bright thing inside the enlarged picture we're showing. Okay, this is the T1 and this is the T2. That's why the difference. Then the MR spectroscopy, you got spectroscopy peaks, the choline, creatinine, NAA, and lactate. The normal brain spectrum, the chemical shift is on the y-axis and the signal intensity on the x-axis. But we are not concerned more with this. You can see that the MS spectrum has there is a reduction. If you see both the overlay of normal versus MS, you can see them. This is the these are the this is the NAA peak, and this is the lipid lactate peak. And this is not present in normal brain, but it appears in MS lesions. And you can see NAA peak is the amplitude is more, and it also that the creatinine and choline, they also are increased. So there is a scope. This is a but not very much given importance, but MRS also can be studied. So let us look at the other biomarkers which are also becoming very important. And one is the visual evoked potentials. The normal P100 wave latency is 100, less than 100. And if it is abnormal, it is 134, and more than 115, 110, you can say okay, is the visual evoked potentials. So that brings us to the point that optic nerve plays a crucial role in diagnosing multiple sclerosis, especially in dissemination in space criteria. Early signs include eye pain, blurred vision, color desaturation, and tests such as visual acuity, VEP, and OCT and MRI aid in detecting optic nerve damage, enhancing diagnosis, and enabling earlier MS detection. So the optic nerve is frequently used for MS diagnosis under the McDonald criteria. Now the latest criteria are in 2024. The symptoms include eye pain, as I said, blurred vision, visual field loss. The diagnostic tests include fundus exams, VEP with delayed P100 latency, MRI for inflammation or atrophy, and OCT showing nerve fiber thinning. So, including the optic nerve in dissemination in space criteria via and plus VEP improves the diagnostic sensitivity without losing any specificity. So these are the various things which you can see. The blurred vision and red color desaturation. You can see how they are seeing the red color. And of course, visual evoked responses, optic neuritis fundus, visual acuity may be lost, and evoked potentials, and then the OCT. So variability in the application of tools you can see, and as the diagnostic evolution took place, all these things have come into place, and you can see the optic nerve in the MRI axial sections. And basically, these abnormalities establish dissemination in space when diagnosing MS. The visual evoked potentials, and if you add optic nerve to that dissemination in space criteria, the sensitivity is increased without losing the specificity, and the accuracy and positive predictive value and negative predictive value. So you can see it increases. So optic nerve is being given more importance nowadays. So optical coherence tomography, which is a non-invasive imaging technique that captures detailed cross sections of the retina, measures the retinal nerve fiber layer thickness and vessel density. In MS, thinning of these layers indicates nerve damage. OCT serves as a sensitive biomarker for visual pathway injury and complements MRI, aiding in assessing the disease severity and prognosis. It's better to understand the structure of the retina and the nerve fibers, ganglion layer, inner plexiform, inner nuclear layer, outer plexiform, outer nuclear, and outer limiting member, and pigmented epithelium. This is the retina. So the retinal nerve fiber layers are like this, and they are divided into no, sectors. So I'm going to show you. We have about 5 cases. When I discuss the cases, then I'll show you them more. So there are studies which said that retinal nerve fiber layer is associated with brain atrophy and multiple sclerosis. The transsynaptic degeneration in the optic pathway that leads to the thinning. The clinically, this thing has been established by studies, and these studies have shown that both RNFL and ganglion cell layer are statistically significantly reduced in patients with MS. both with and without prior non-optic neuritis. So whenever a report is given, the measures retinal nerve fiber thickness to evaluate optic nerve health, important in MS. That tomograms are displayed and thickness maps for the both eyes are displayed, which we'll see in the cases. Normal eyes show thicker superior and inferior quadrants and symmetry. That you keep in. So when I'm going to show one case there, the right eye shows significant thinning, left eye is mostly normal. These findings align with optic neuritis and MS-related nerve damage. So retinal imaging, retinal GCL thinning. So retinal fiber layer and ganglion cell layer thinning reflect axonal and neuronal loss. The non-invasive, high-resolution imaging provides cross-sectional views of the retina. May serve as a sensitive biomarker for visual pathway damage, and that is dissemination in space. So there are key thresholds for optic nerve involvement by OCT, that is the OCT RNFL inter-eye asymmetry more than 5 micrometers, and that is significant. And the ganglion cell layer asymmetry more than 4. VEP, as you know, more than 115 milliseconds, that shows delayed conduction. And the clinical trial evidence also is there. The multi-center trials have showed adding optic nerve improves dissemination in space performance. RNFL thinning predicts disability worsening. So longitudinal validation has been done in these cases. And if you add VEP to OCT, they complement each other. Functional plus structural abnormality. And this has become one of the important points in the optic nerve as a fifth topography in the 2024 McDonald criteria. Dissemination in more than 2 topographies, optic nerve pathway, and meets the dissemination in space, optic nerve as fifth site. Then the brainstem auditory responses, you can see the, the waves 1, 2, 3, 4, 5, 7, and the horizontal it is milliseconds, and the y-axis shows the amplitudes. You can see the latencies of 1.54 and 3 is 3.62 and 4 is 5.36. So the inter-peak latencies have got some important, which I'm going to discuss. The x-axis represents the time measured in milliseconds, which we have seen. The y-axis displays electrical potential in microvolts. So 1 to 7 peaks reflect the successive activation of the auditory pathway components ranging from the cochlea to the brainstem. The normal peak assignment, we all see these are all milliseconds. The wave 1 is 1.5 milliseconds. Distal auditory nerve, the cochlear nerve and near cochlea, this potential is picked up. The wave 2 is about 2.5 milliseconds. Proximal auditory nerve, that is near brainstem entry, this wave 2 forms. Wave 3, 3.5 milliseconds, this is a cochlear nucleus, lower brainstem. And fourth and fifth, 5 to 6 milliseconds, superior olivary complex and lateral lemniscus pons and midbrain. And sixth and seventh, higher brainstem, midbrain auditory structures. So actually, we always talk of 1 to 3 and 3 to 5 latencies. So these are the important latencies which we always calculate. And these are the normal values which I showed here. And you can see the conduction delays in MS. The distal auditory nerve, 1.54 not disturbed. Proximal auditory nerve, 3.62. Superior olivary complex. So if there is MS delays, the cochlear complex is fifth and the seventh. So these delays in the last ones. So 1 to 3 and 3 to 5 or 6. These are the more important conduction delays that happens. So in multiple sclerosis, demyelination of the auditory pathways leads to delayed wave 3 or 5, increased interpeak latencies of 1 to 3, you have to remember this, 3 to 5 and 1 to 5. And asymmetrical responses between ears. There may also be reduced amplitude or absent waves of these. The delays in 1 to 3 suggest lesions in the lower brainstem. 3 to 5 delays in indicate upper brainstem involvement. and 1 to 5 latency reflects widespread conduction slowing. These clinically silent lesions, indicating subclinical brainstem involvement, is identified by BAER test. And BAER helps to demonstrate dissemination in space as part of the McDonald criteria, and it serves as a functional biomarker in conjunction with OCT, VEPs, and MRI. These are somatosensory evoked responses. You can see the stimulation and the various waves, the N9, N13, N20. You can see how they are originating when the stimulus is given here. In the median nerve, the EP1, EP2, the electrodes which are attached, and you can see the waves of somatosensory evoked responses. The electrical stimulation is delivered to the median nerve at the wrist. The responses are captured at the brachial plexus, cervical spinal cord, subcortical relay stations, and the somatosensory cortex. That is the C3 and FZ electrodes which we have shown you. This is the somatosensory cortex. The peaks identified are N9, N11. You can see P11, P13 and 14, same there, and N20. They represent conduction through various neural pathways. The letter N denotes a negative peak, and while the P denotes a positive peak. You can see the positive peaks and the negative peaks. Positive peaks are down, P11 and P13, 14 down. The negative peaks are up. So N is negative and P is positive. The latency times are recorded in milliseconds. The standard peak latency is, what is N9? It is brachial plexus. This is peripheral conduction. N9 is brachial plexus. N11 dorsal root entry zone, cervical spinal cord region. So N11 is this. This is a N11 dorsal root entry zone. Okay. N13 cervical spinal cord, and P13 and 14 brainstem relays. So let us look at the N13, which is cervical spinal cord. And these are brainstem pathways, P13 and 14. And N20 primary somatosensory cortex, that is the postcentral gyrus. So P13 and 14 basically medial lemniscus and thalamus. So this is N20 is the postcentral gyrus and the sensory cortex. So now you got the good idea of what is this biomarker, SSCP or SSC response. Prolonged central conduction time is N13 to N20 interval is called prolonged central conduction time. Absent or delayed N20, that is cortical potential. Prolonged P13-14 latency is brain stimulation. Asymmetry between left and right side. So if N9 is normal, N13 is delayed, indicates a spinal cord lesion. If N13 is normal, N20 delayed suggests a supraspinal brain stimulation. The abnormalities in both N13 and N20 point to multifocal disease commonly seen in MS. So SSCS PPs can detect subclinical lesions within the sensory pathways. They support evidence for dissemination in space according to the McDonald criteria. SSCPs complement findings from MRI, VEP, and BAER tests. These are all functional biomarkers, the functional confirmation of this load conduction beyond structural changes seen on MRI. So SSCPs assess conduction along the pathway from the peripheral nerve through the spinal cord and brainstem to the cortex. In multiple sclerosis, extended central conduction times, particularly delayed N20, indicate demyelination in the dorsal column, medial lemniscus pathways, making SSCPs a valuable biomarker for subclinical involvement of sensory pathways. So we have seen all the optic nerve and other things, BERA and SSCP and VEPs. So you can see the somatosensory evoked responses. See, brainstem, median nerve, that's what it is going on, and cervical cord, brachial plexus, right? So this is wrongly placed here. This is the stimulation, and you can see the median nerve and brainstem. This is the brainstem area. This is spinal cord area, and this N20 is the cortical area. So there may be delays in these various waves. That comes to the important aspect, that synthesis of IgG inside the CSF. So there's dissemination in space along with positive OCB. So if OCB is also present, it's sufficient to diagnose MS. There is no requirement of any dissemination in time. So the recommended technique is agarose gel electrophoresis with isoelectric focusing and immunoblotting or immunofixation for IgG. So that's how the MS, the oligoclonal bands are seen on this picture. You can see 1, 2, 3, 4, 5. They are present. The agarose gel electrophoresis, isoelectric focusing, and immunoblotting, immunofixation. These are all used to detect the IgG. Combining spatial dissemination, that is DIS, with positive oligoclonal bands confirms MS. The key points are OCBs indicate dissemination in time, allowing earlier diagnosis confirmation. So this is the DIT parameter. So there's one more thing that has come up, that is a cup of free light chain and ratio. This is also being increasingly used, and the KFLC ratio in CSF compared to serum. This is and corrected for albumin. That is a KFLC index, it's called, and it is increased index may replace OCBs in diagnosing MS. But KFLC testing is more straightforward, quicker, and highly sensitive. It's becoming a promising surrogate marker for dissemination in time. So OCBs and KFLCs are dissemination in time parameters. This is measured in CSF and serum, and the CSF KFLC by serum KFLC divided by CSF albumin by serum albumin. It is a surrogate for OCBs, highly sensitive, rapid, automated testing, and less subjective than OCB detection. And so KFLC index is emerging as a robust, cost-effective, faster alternative to OCBs for demonstrating intrathecal IgG synthesis in MS. So oligoclonal bands and KFLC, the OCBs detected by isoelectric focusing and immunoblotting appear in about 95% of the MS cases and are the gold standard for identifying intrathecal IgG production. The kappa-free light chain index, calculated as I said earlier, indicates intrathecal IgG synthesis with similar sensitivity and offers faster, automated, and less subjective results. Both these demonstrate intrathecal IgG synthesis, and so KFLC is emerging as a practical surrogate for OCBs in MS diagnosis. The reference is given here. So there are other biomarkers which are also being talked about then in various studies, like in the study of Asclepios, that is ofatumumab, and Opera, that is ocrelizumab, and Radiance, ozanimod, and ponesimod in Optimum, natalizumab, and ibudilast. These neurofilament light chains have been studied in this, but still they are not being used as a diagnostic criteria. Another biomarker is GFAP, that is glial fibrillary acidic protein. Saponimod study and progressive MS cohorts are studying this. And we have already discussed about kappa free light chains. A lot of meta-analysis and lab validation studies are available for this. The emerging biomarkers, that central venous sign and paramagnetic ring lesions, and there's a CAVS NMS study and multi-center validation and automation has already been done. So if you look at these biomarkers and what is the utility, clinical utility of these biomarkers, prognosis and treatment response is for NFL, progression biology for GFAP, KFLC is diagnosis, and CVS and PRLs are diagnostic specificity. So the all these two are diagnostic and two are prognostic. So now we enter the arena of the diagnostic criteria in multiple sclerosis. It has evolved since Charcot's 1868 triad, leading to the now 2024 McDonald criteria, which use advanced MRI for earlier accurate detection. So it's such an old disease, 1868, 1968, now you're 2025. 2024 McDonald criteria were finalized at an international meeting in Barcelona with 56 experts from 16 countries. What they did was a consensus driven voting process refined the guidelines to balance sensitivity and specificity, combining clinical knowledge and technological progress, which we are going to look in the end. The last criteria, last slides will be on 2024 McDonald criteria. He is the chap who first did the triad, that is Charcot in 1868, nystagmus, intention tremor, scanning speech, with no other evidence for anything. He described MS. And Justice Potter, diagnostic criteria subsequently have come. So if you look at this, 1868, nystagmus, intention tremor, scanning speech, first clinical description, there is no dissemination in time requirement here. Shoemaker criteria, 1965, we are going to talk about this. Age more than 10, and age should be between 10 and 50, more than two CNS regions, more than two episodes, more than 1 month apart, excludes mimics, early structured clinical criteria. These are the first ones which come. And then when I was doing MD, the poster criteria have come. Clinically definite and probable MS categories have emerged. And they introduced diagnostic stratification. Here, first time, we started looking at MRI, VEP, BERA, SSEP, and oligoclonal bands. And Barkov MRI lesions in multiple CNS regions paved way for MRI in diagnosis. And McDonald in 2001, MRI for dissemination in space and time is used. It allowed earlier diagnosis. And these criteria have been revised 2005 also, 2010, 2017, 2024. So here the refinement is dissemination time and space, and there are also criteria for primary progressive MS, increased sensitivity and earlier treatment, and Barcelona consensus statement, as I said, more than 80% agreement should be there. And here also balance sensitivity and specificity, updated global standards. So these are the main criteria for diagnosis. And what diagnosis is based on white matter tracts, pyramidal pathways, cerebral pathways, medial longitudinal fasciculus that leads to internuclear ophthalmoplegia. We discussed at length optic nerve, the posterior columns. So these lesions are documented. The second lesion, if they have a P100 and latency prolongation. So what are the MRI criteria? There are 4 lesions in white matter or 3+1 periventricular region. The size should be more than 3 millimeters. If it is more than 50 years, it is more than 5 millimeters. Lesions should be adjacent to the body of the lateral ventricle and or can be in the posterior fossils. After a clinically isolated episode, MRI can be used after 3 months to document dissemination in time. That was how it started. So now let's look at the shoemaker who doesn't have any of the facilities available right now to diagnose MS, but brilliantly brought out these criteria, these things still we use. So neurological examination should reveal objective CNS abnormality, mostly white matter involvement, mostly white matter involvement. I told you what are white matter tracts. You want to so go in pyramidal lesions, ataxias, weakness of pyramidal nature, internuclear ophthalmoplegia, optic neuritis, and imbalance ataxia, sensory ataxia. So one or more sites of CNS involvement, but how they should involve? One or more each lasting for more than 24 hours, separated by more than 1 month, chronic progressive more than 6 months. Age of onset 10 to 50 years. He thought that more than 50, after 50 years, the MS is less common. So there should be no better explanation of the symptoms. These are Shoemaker's criteria of 1965. Then the Poser's criteria came, affecting 2 regions separated in time and space, the clinically definite MS. Here, the paraclinical evidence appeared for the first time, which indicates evidence of subclinical lesion by MRI or evoked potentials. So, MRI has become the tool of choice in supporting MS diagnosis. Typical white matter hyperintensity is in 97% of clinically definite MS. The presence of CSF oligoclonal bands in 95% sensitive in CDMS, but not specific indicator of MS because these can be seen in other diseases also. So when we read this Posner criteria, it used to be nightmarish to remember all this clinically definite MS, lab supported definite MS, clinically probable MS, lab supported probable MS, depending on the number of attacks, the clinical evidence, and the paraclinical evidence and oligoclonal bands. The paraclinical evidence is all the evoked potentials. So we have gone through this era reading Prosser's criteria. And then came the MacDonald criteria. The criteria are named after Ian MacDonald, a New Zealand neurologist who died in 2006, who developed these original criteria with his international colleagues in 2001. Okay, this is the 2001 it started, and the criteria were originally introduced 2001, revised in 2005, 2010, 2016 by Magnames, 2017 and 2024. So see how many revisions have gone place. That means MS is a very complicated disease. Diagnosis is not so simple. We are not certain whether we are doing the right thing, but we keep on recommending costly medicines with impunity, right? We always do that, but we should know what are our limitations. So the timeline of McDonald criteria revisions 2001 to 2004, the original McDonald criteria 2001, first revision 2005, we'll see why, second revision 2010, and 2017 revisions. The magnums have come in between, latest is 2024. So 2005 refined MRA criteria. Further MRI updates improved sensitivity in 2010. Magnum's proposal with imaging refinements in 2016. OCBs have come back, a substitute for dissemination in time, and integration of all these radiological isolated syndrome, KFLC, CVS, and PRLs in 2024. So if you look at this, the original McDonald criteria, which were introduced in 2001, so the key features which are listed here, but we'll again discuss subsequently. So what happens? Need 3 out of 4 in the 2001 criteria, more than one gadolinium enhancing lesion or more than 9 T2 brain cord lesions. So we started counting all the lesions. More than one infratentorial lesion, brainstem or cerebellum, more than one juxtacortical lesion, more than 3 periventricular lesions, ventricles. It's very difficult to remember and extrapolate onto the diagnosis. You have to keep this on a paper and keep looking at the lesions and keep counting them. You require any 3 of these 4 to say it is DIS. For time, new gadolinium enhancing lesions more than 3 months after onset, plus with a new site. The new T2 lesions more than 30 days after onset. So GAD enhanced more than 3 months, T2 lesion more than 30 days, and another site. The supportive tests are oligoclonal bands, VEPs, clinical signs and symptoms. This has been refined subsequently. So we have already done, so I'm not going to go through this again. In 2001, we have already seen this. So the 2005 criteria, they proposed revisions included accepting multiple spinal lesions over 3 millimeters and under 2 vertebral body lengths instead of brain and infratentorial lesion criteria, replacing an enhancing brain lesion with an enhancing spinal cord lesion, and shortening the new T2 lesion discovery interval from 3 months to 1 month for time dissemination. The DIT has become from 3 months to 1 month, and spinal cord lesion has made its appearance in 2005. So if you look at that, dissemination in time, new T2 or GAD enhancing lesions on follow-up MRI, at least one T2 lesion in more than two of the four regions. These topographies are very important: periventricular, juxtacortical, infratentorial, and spinal cord, which I've already shown you once. So if you look at this, the periventricular, more than three lesions; cortical or juxtacortical, more than one lesion; optic nerve, more than one lesion; infratendon, more than one lesion; spinal cord, more than one lesion. These are all suggest dissemination in space. The T2 lesions are identified at least two of the following set locations. Dissemination time identified by a new lesion on follow-up scan, which is very easy to remember. If another new lesion appears, dissemination time. An asymptomatic enhancing lesion plus a non-enhancing lesion on one scan also suggests. And for primary progressive MS, the disease progression for at least 1 year, meeting the dissemination spice criteria. So after this, we'll go on to the McDonald 2010. Here, new T2 and GAD enhancing lesions on follow-up MRI. There should be simultaneous GAD and non-GAD enhancing lesions for dissemination time. For the dissemination space, the same topographies, more than one T2 lesion in more than two of the four regions. Okay. So the criteria which in 2017, you start the patient with suspected demyelinating attack and you do the MRI, look at the brain and spinal cord. Step 2, are there T2 lesions in typical MS locations? What are these locations? Periventricular, cortical juxtacortical, infratentorial, spinal cord. If there are no lesions in these typical locations, consider alternate diagnosis and repeat MRI. Then if the lesions are present there, you then go to step 3. You check the distribution. More than one T2 lesion and more than two of the four typical regions, not enough. If they are not present, they are not enough for dissemination space. Then again you repeat the MRI. If yes, then you go to step 4. You look for symptomatic lesions and also count. In 2017, both symptomatic and asymptomatic are counted towards dissemination in space. What is the count which you have to do? More than one T2 lesion and more than two of the four typical regions. You have to see that. So if dissemination in space is satisfied, more than T2 lesion across more than two typical areas. Just remember this, more than one T2 lesion across more than two typical areas. Then you demonstrate dissemination in time, new lesion and follow-up, or CSF OCPs. So only these two lines you have to remember. More than one T2 lesion across more than two typical areas. So why you need for dissemination in space more than one T2 lesion? They must span at least two of the four MS typical regions. These are periventricular, cortical juxtacortical, infratentorial, and spinal cord. The 2017 update, the regions that cause the patient's current symptoms now do count towards him dissemination space. Earlier, it is only asymptomatic lesions. Now, the symptomatic lesions are also taken into consideration. Optic nerve is not included here also among the four MRI topographies for DIS. That is the fifth topography that is included in the 2017 24 criteria. The overall diagnosis, dissemination space plus dissemination time, or CSF OCBC as substitute for dissemination time per 2017 criteria in the appropriate clinical context. So the 5 criteria categories of 2017 are number of clinical attacks, like in Poser criteria, 2 attacks involving 2 or more lesions within clinical evidence, no extra data is required. 2 or more attacks with one lesion and a history of a prior lesion, no additional data. 2 or more attacks with one lesion but no prior history, MRI confirms spatial dissemination. Only one clinical attack, that is clinical isolated syndrome, more than 2 lesions with objective clinical signs showing dissemination in time on MRI or positive CSF specific molecular bands. So clinical isolated syndrome with a single lesion displaying objective clinical signs demonstrates DIS on MRI along with dissemination time on MRI or CSF specific oligobands. The point to remember is radiological isolated syndrome. You diagnose, right? So 17 criteria update shows early multiple sclerosis diagnosis in clinical isolated syndrome patients using MRI and CSF follicular bands without MRI evidence of DIT and includes symptomatic and asymptomatic MRI lesions for assessing dissemination space and time. So you can see the periventricular lesions, the cortical lesions, the juxtacortical lesions, which are seen here and here also, and more than one T2 lesion in more than two topographies, that is spinal cord also. So this we have already said, and we are not going to discuss. The clinical isolated syndrome is the first episode of neurological symptoms lasting at least 24 hours. This is different from radiological isolated syndrome. Clinical isolated syndrome is defined like this. So RS can be defined as the presence of asymptomatic lesions on typical of MS. So one is clinically isolated syndrome, the other one is radiologically isolated syndrome. As you have seen this graph already, the inflammation goes on leading to degeneration. So from time of the clinically isolated syndrome to diagnosis, how it changed over the years because of the diagnostic criteria. Poser mean time to MS diagnosis 2.8 years if we apply that. McDonald has brought down in 2017 to zero point 0.4 years. OCB is accepted as substitute for DIT. In now it is about 0.3 years with the present diagnosis. So overall reduction from Poser to McDonald mean time from clinically isolated syndrome to MS diagnosis decreased by 75%. So diagnostic of multiple sclerosis has evolved such a rapid space, and you can see the time from clinically isolated syndrome to MS diagnosis, and you can by various criteria come down slowly and over the years. So what impact McDonald criteria revisions had on MS diagnosis? If you see in 2010, the clinically isolated syndrome is 63%, MS is the remaining. And it has shrunk to 32% in 2017. Now, with the present criteria, 20, it shrunk down to 20%. So, the diagnosis accuracy has tremendously improved, and the application, there are some contributions to MS misdiagnosis, like atypical neurological symptoms, 65%. Historical dysfunction without objective evidence, people say things, 48%. Over reliance on MRI abnormalities and non-specific symptoms, 60%. And misinterpretation of juxtacortical periventricular lesions, 33%. MRI slice variability mistakes, 24%. So there are present problems in the diagnosis which we should be very much aware. So duration of misdiagnosis, and now let's look at some cases which will make it interesting. A 31-year-old woman with no prior health issues experienced sudden worsening vision loss, eye pain in her right eye. Diagnosed with optic neuritis, she received IV methylprednisolone. MRI showed optic nerve inflammation and a brain lesion. Vision initially declined but improved over 3 months to the near normal. Tests for NMOSD, MOG antibodies were negative with no systemic or spinal cord involvement. You can see the optic nerve involvement in this MRI, and worsening loss and eye pain of the right eye. You can see the right eye as this is the MRI thing. So they did the OCT, and you can see OCT sector, superior, inferior, temporal, nasal, thickness. And this is right eye and left eye. Do you make a diagnosis of MS by McDonald criteria in this case? Because it is reflecting the thickness. We also included the fifth topography, and you can see the normal findings, and the values are given here: 54, 59, 116, 70, 74, 104. But we see the thinning of superior and inferior regions or quadrants is very significant. So the RNFL thickness, you can tabulate like this and judge. The left eye is OS and the right eye is OS. And see, these are the normal ones, whole. But in the right eye, the superior reduced, inferior reduced, temporal severely reduced, nasal borderline, overall symmetry asymmetric, right? Clock over sectors, multiple abnormalities. So that's how you see the OCT, and these are the affected, and these are unaffected. This is a normal OCT, and this is the abnormal OCT. So you concentrate on these quadrants, RNFL quadrants, to interpret this, because ophthalmologists don't write anything and just give you the test. They do it the test and hand over you the graph. So 31-year-old female with acute right optic neuritis, periventricular lesions, CSF positive OCBs, NMOSD negative, no spinal cord lesions, typical clinically isolated syndrome, meets a diagnosis DIC and DIT via OCBs. So early optic neuritis with OCB positivity is highly suggestive of MS, and the exclusion of mimics is key in this case, right? Right. The second case. 43-year-old healthy woman presents with double vision described as diagonal in all directions. The ophthalmologist notes diplopia when gazing far left on left-sided ptosis. The double vision worsens over 2 to 3 weeks. 5 weeks after the symptom onset, brain MRI reveals T2 hyperintensities in periventricular area, small pontin lesion, and a GAD-enhanced lesion periventricular. 2 months after onset, the neurological examination is normal. So you can see a diagnosis. Do you make a diagnosis of MS in this case or not? The lesion is there, the double vision, clinical picture, and the visual loss, and with a MRI hyperintensity, which is GAD enhancing, suggesting active lesion. So this 43-year-old woman presented with subacute diplopia and mild ptosis. MRI revealed multiple periventricular T2 lesions, small pontin lesion with a gadolinium enhanced periventricular lesion. After 2 months follow-up, neurological examination was normal. MRI findings fulfilled the criteria for dissemination in space and time, and her early MS symptoms resolved completely. The single clinical episode plus MRI evidence of dissemination in space and time allows MS diagnosis per McDonald 2017 criteria, even if the symptoms have lost. So summary, the lady with diplopia, pontin periventricular lesions, plus pontin plus periventricular, GAD enhancing periventricular lesion. The comment is there is dissemination in space, there is a dissemination in time, because enhancing and non-enhancing both are present. That meets MS criteria. MRI evidence can establish diagnosis even if clinical examination is normal. The healthy control MRI, a 50-year-old woman, healthy control for research MRI, it showed 3 periventricular, 2 juxtacortical, 1 infratentorial, 1 spinal cord lesion. CSF showed elevated kappa free light chain index. Do you make diagnosis of MS by 2017 McDonald criteria? Yes. This lady with multiple CNS MRI lesions and an elevated KFLC index meets criteria for radiologically isolated syndrome. While MS cannot be diagnosed without symptoms, the positive KFLC indicates the increased conversion risk. So radiologically isolated syndrome warrants monitoring. Diagnosis of MS is only considered if symptoms emerge. So asymptomatic volunteer, MRI has got lesions, CSF positive, dissemination in space is present, no clinical event. It is called radiological isolated syndrome, not MS. RIS does not meet 2017 diagnostic criteria but carries the risk for conversion. The last 2 cases. 66-year-old woman developed a muffled hearing, ear fullness, and tinnitus after flight. She experienced a recurrent vertigo lasting hours every few days. MRI shows brain lesions suggestive of MS, but lumbar puncture is negative. Physical examination is mostly normal, except reduced toe vibration sense. Neurological notes the neurologist who examined, he noted the right beating nystagmus and considers Meniere's disease or migraine as diagnosis. Will you make a diagnosis use these criteria? So what is the summary? This here got a vertigo, a 66-year-old lady, mind you. Shoemaker said no MS after 50 years. Developed vertigo and tinnitus after a flight. MRI revealed periventricular, juxtacortical, medullary lesion, but CSF lacked oligochronal bands. Exam showed mildly reduced vibration sense. Given her age, vascular risks, and negative CSF demyelination less likely. It now vestibular migraine, menias, age-related changes come into picture. So MRI findings in older patients with the typical symptoms and absent OCBs should be interpreted with caution, as McDonald criteria for MS are likely not fulfilled without a clear demyelinating event. The summary says clinical radiological correlation is vital. Avoid overdiagnosis in atypical syndromes. And this one is a particularly atypical syndrome. Last case is a 44-year-old healthy woman on a business trip, presents with flu-like symptoms and cold sores. She then develops leg heaviness and urinary retention, leading to catheter placement. She returns to hometown and is admitted to the emergency department. The physical examination is unremarkable aside from the urinary retention. MRI of thoracic spine shows a non-enhancing lesion from CA to T12, TA to T12. Cervical MRI shows multiple enhancing lesions. Brain MRI demonstrates non-enhancing periventricular and infratentorial lesions. CSF analysis reveals 36 mononuclear cells, normal protein and glucose levels, no OCBs. Serum testing for aquaporin 4 and MOG is also negative. So these are the MRI pictures. And do you make a diagnosis of MS using the criteria? What is the summary says? It's a flu-like illness, cold sores, followed by urinary retention, longitudinal extensive non-enhancing T8, T2 lesion, enhancing cervical spine lesions, non-enhancing brain lesions. CSF revealed pleocytosis without oligochronal bands, aquaporin 4 antibodies, and MOGs are negative, although the lesion pattern suggests dissemination time. Features such as LETM, negative serology, and absence of OCB are atypical for MS. The viral prodrome raises the possibility of para-infectious myelitis. So while MS is possible, alternative demyelinating disorders must be considered. So consider mimics in atypical cases, OCB absence reduces likelihood of the MS. That's why it's very important. So all these cases, if you compare with the 2017 and now 2024 classification, so you have to now see what has changed. The problem is KFLC has come, which is replaced, and the other things have come, that is the central vein sign and PRLs have appeared in these cases. So, friends, these are the summaries of these cases. So, let's end by the differences of the core differences of 2017 and 2025 or 24. The core structure requires clinical attacks and evidence of dissemination in space and time to diagnose MS in 2017. Here, it allows diagnosis using imaging CSF biomarkers with expanded options. There is OCPs, there is KFLC, DIT, CVS, made together permit diagnosis even without a classical clinical attack. About the dissemination in space, you require more than 2 of 4 regions, that is periventricular, cortical, infrarenal, spinal cord. In 2017 criteria, the same here, but advanced MRI markers, CVS plus, paramagnetic rim lesions can strongly support MS and are integrated into decision making. Dissemination in time, new T2 or GAD enhancing lesions and follow-up MRI are simultaneous enhancing, non-enhancing lesions. CSF specific OCBs are required. As in 2017, but here the KFLC index as CSF positivity for DIT per slide. That has happened. So CSF biomarkers, kappa free light chain index accepted as CSF positivity in 2025. And advanced MRI techniques, CVS positivity, the central venous sign positivity, and paramagnetic ring lesions can be used to increase specificity. So this is CSF DIT, that you can say that it's MS. So typical exclusions rule out better explanations in 2017. Same principle here also. Explicit attention to NMOSD MOGAD remain critical even without biomarker heavy pathways. So 2017 McDonald criteria allow earlier MS diagnosis when MRI and CSF support dissemination space and time, but they still require a typical clinical syndrome. Radiologically isolated findings or atypical presentations should be approached with caution to avoid misdiagnosis. So, in summary, of 2024 or 25, you can say periventricular, dextrocortical, infratemporal spinal cord, optic nerve, five topographies have happened now. Kappa-free light chain index can substitute for OCBs, CVS, and PRLS as supportive markers. And radiologically isolated syndrome criteria, lesions in more than three characteristic locations or one to two locations plus OCBs and spinal cord lesions and or dissemination time. McDonald 2017 criteria, dissemination in space, time plus OCBs. CVS also is sufficient here. So there are revisions, and the revisions have introduced all these various biomarkers. So that's all from my side about the biomarkers in multiple sclerosis. We have reviewed MRIs, we reviewed visual evoked responses, optic nerve, and we reviewed BERA and SSEP and the kappa light chain complex. And so we've gone through the Shoemaker criteria, the Posner criteria, the 2001, 2005, 2010, 2017, 2024 McDonald criteria, and the recent introduction of the new biomarkers into the diagnostic criteria, that is paramagnetic ring lesion, central vein sign, and all these things now have a very high impact in diagnosing multiple sclerosis. Any questions? Are you all there or are all gone? Hello.
No, sir.
Did you understand? Do you want to ask any questions?
No, sir.
Hmm. So you understood the biomarkers completely, and at least a bit of electrophysiology, which is helpful in the exam. You can write
Yes, sir.
two lines
Yes,
about,
sir.
yeah. So it may be available on YouTube for the revision of the electrophysiology biomarkers. Okay, then. Thank you very much. Good night.
Thank you, sir.